I need everyone just to go. Where is this? Where is it, the slide? This is all طبعا there is, you have no picture, especially for the, where is the slide? This is the one? Yeah, I think I need everyone just to register. It is our meeting today. It is a scientific meeting about tirzepatide and the benefit. As you know, that the GLB receptor agonist is not only the weight reduction; it has a lot of other medical benefit. So today we go through the benefit of the tirzepatide as weight reduction and cardiac and fatty liver and respiratory, even apnea, sleep apnea. So I think everyone from, so we'll have first meeting طبعا I think Prof. Walid Al-Bakr from Dammam, he is ready. He's a professor of internal medicine and endocrinology. Imam Abdul Rahman bin Faisal University, consultant of endocrinology and diabetes, American and Canadian board in medicine and endocrinology, evidence-based care in type 2 diabetes management. I welcome him, Dr. Walid.
Thank you very much, Prof. Abdulrahman, for a nice introduction. And thank you all for attending this lecture and I hope you find it useful. I would like to thank also Lily for inviting us for this scientific meeting, and I hope you find it useful. So, what I will talk about this section about the evidence-based care in type 2 diabetes and unlocking the new possibility. So this is my disclosure, and basically you can read it. So, okay. And I would like just to mention about that throughout, if you look throughout the world, many patients with type 2 diabetes, unfortunately, they don't achieve the glycemic control, as you know, in spite of currently available therapy. In Europe, for example, only 44%, in US 49%, and in Saudi Arabia almost 69%. We're talking about two-thirds of our patients, they are not actually achieving the glycemic target as per ADA guideline. In Japan, 51, and in England also is 63%. So it seems globally we're not achieving actually the target actually. And most patients with type 2 diabetes in Saudi Arabia have an excess weight. And if you practice clinics, in diabetes clinic, you will see many of our patients having type 2 diabetes with actually obesity. And the prevalence of diabetes is high among Saudi population and represent a major clinical, problem and public health problem. So among people with type 2 diabetes, you can see 8 out of 10 have obesity and overweight. So definitely obesity is prevalent. I was joking that, do you know what is the prevalence of obesity in Vietnam? Do you know what's the percentage? The prevalence? Only 1%. 1% is the lowest worldwide that is. And you can see that our prevalence is really high compared to other countries. Again, the lifestyle, it play part of it. Of course, the genetic play part of it. So we are definitely among countries with the highest actual risk of obesity. So according to the ADA and ASAD, actually, contest report, in type 2 diabetes, high magnitude of weight loss lead to better outcome. And this is very well documented. So that 5 to 10% yield a metabolic improvement if you lose 5 to 10%. And of course, 10 to 15% if you lose it, this will have more a disease modifying effect and lead actually to remission. And people with type 2 diabetes can especially benefit from early aggressive treatment, and damage caused by type 2 diabetes present early compared to the ongoing life benefit of early aggressive treatment. So the key here is that it's very important that early intervention of type 2 diabetes is so critical and important. So this is a study from UK, well-known prospective diabetes study, UK BDS trial, the well-known trial which showed that early glycemic control from the time of the diagnosis actually have a greater impact of the long-term benefit. And the result demonstrate a legacy effect actually in which lowering A1C by 1% of the time of the diagnosis had a greater impact actually on the clinical outcome than delayed actually control, which show that if you control those people early and intensively, that will be better and have a legacy effect at the long term. So if you look for that here, that in diabetes and aging study show that a lower A1C early after the diagnosis was associated with a lower risk of microvascular and macrovascular complication. Very well documented, and you can see that very clearly here with the hazard ratio of microvascular and complications. As your A1C is go higher, the hazard ratio actually will go higher in two sides, in microvascular and macrovascular complications, and this is very well documented. We know that the higher A1C, the more complications that you had in, of course, diabetes complications. So let's take a case here. We have Nora. Nora, she is unsatisfied with her A1C and weight, and she's concerned about her future with type 2 diabetes. Nora is making the effort, but not seeking the result. She was recently diagnosed with type 2 diabetes, has not reached her glycemic target on metformin alone, and continue to struggle with her weight in spite of her effort with diet and exercise. So excess weight is a key component of her type 2 diabetes pathophysiology, as you know. So now talking about tirzepatide is, a molecule that designed actually to activate both GIP and GLP, as you know. And it's highly selective of human GIP and GLP. It has high affinity to both receptors, and the activity actually of tirzepatide on the GIP receptors is similar to the naive GIP. And of course, if you look for the dose adjustment, doesn't need any dose adjustment for patient with renal impairment, including end-stage renal failure, and no dose adjustment also in patient with hepatic impairment. And that gives you a good, zone for treating a patient with complications at kidneys and liver problem. So how the GIP and GLP receptor agonist tirzepatide work, as you all know, that clinical studies show that tirzepatide, it reduce energy intake and appetite, as you know, and increasing fat oxidations, feeling of satiety and fullness, and decreasing food craving, and of course tendency to overeat, and reactivity to environmental food noise also. It definitely lower the body weight and body fat, and further reductions result in reductions of the visceral fat. Let's talk about the SURPASS trial. And SURPASS trial is basically a study which, including those patients with tirzepatide, is over 40 weeks phase 3 study where they treated patient with, tirzepatide 2.5, and the escalation 2.5, 7.5, and escalation to 15. And you can see for also for semaglutide, and basically they compare the different dosage of tirzepatide compared to the other comparator, which is the semaglutide, as an add-on therapy to metformin. Well-known study and landmark where it's actually look at the SURPASS show that tirzepatide provided a superior actually A1C reductions compared with the semaglutide 1 milligram. So you can see in the gray area is the semaglutide and show reductions of A1C by 1.9 at the high dose. If you look for the tirzepatide at dose of 5 milligram, it reductions actually by 2.1 of A1C, and you can see of the 10, which is about 2.4, and of course the 15 about 2.5% of A1C reductions. Same, actually, if you look to the weight, again, continuation for that show a sustained A1C reductions compared with semaglutide. So it has a durable effect and sustained throughout. And I'm sure you observe a lot of our patients when they started on that, they have good durability of they maintain the A1C in good target, especially if you start them early, intensively, you can maintain for long durations with a better actually A1C reduction. So yes, tirzepatide delivered significant A1C reduction from baseline over 40 weeks, and these reductions actually start as early as week 4, and actually it's continue and is very durable. If you look for the the percentage that the significantly most patients achieved A1C of less than 6.5. If you remember, almost 65% of our diabetic patients, they're not achieving the target. Now, if you look to this slide, that significantly more patients achieve A1C less than 6.5 compared to semaglutide. And if you look for here, you can see the A1C, those with less 6.5, you can see the percentage is ranging from 60 to 87%. They achieve target less than 6.5%. This is very impressive. More than 2/3 they can achieve the target, and this is what we would like. And we know, as we said, that an old dosage actually of tirzepatide help achieve the target. and it's actually even superior to other competitor like semaglutide. Again, if you look for A1C reductions by baseline A1C less than 8.5 and more than 8.5. This is very nice subgroup analysis where they found that early start of tirzepatide effectively lowered A1C whether baseline value was above or below 8.5. So this is very, very important to know. If we look for the weight reductions, and I'm sure a lot of you come across this study where when you compare these three dosage of the semaglutide, 2.5, 5, 10, and 15 versus 1 milligram of sema, you can see that there's clearly tirzepatide 15 milligram is double the weight loss versus the semaglutide 1 milligram. So yes, weight reductions actually is even better. And if you look at it in here, you can see very clearly the superiority even of 5 milligram of tirzepatide is superior to 1 milligram of the semaglutide. Those are in type 2 patient, type 2 diabetic patient, if you are targeting, A1C reductions as well as weight reduction. And if you look for tirzepatide helped more also patients to achieve weight loss, more than 5% and more than 10% and 15% at every dose compared to semaglutide. And you can see those who achieve weight reduction more than 5% is up to reach, actually in different dosage, reach to 82 to 86% in dosage of 10 to 50 milligram, and compared to semaglutide, 58%. But if you look for those who achieve weight reduction more than 10%, majority 50% and above. And if you look for those who achieve more than 15%, it's almost 28 to 40%. They achieve actually weight reductions more than 15%. So I'm sure you can get actually more than this. And we see there's diversity of people responding to tirzepatide. Different from others, we see people who respond significantly, even more than this number, and maybe less, sometimes not, maybe less than others. If you look for the GI, the side effect of medication is well known. Like all side effect, is nausea, diarrhea, vomiting, dyspepsia, decreased appetite, constipation, especially those patients with gastroparesis, with peptic ulcers, irritable bowel syndrome, or having GI side effect. So usually the more manifest actual side effect than others. So usually I ask them about the side effect, about the GI symptoms before I start. I might sometime pre-medicate them and prepare them actually before they start actually this medication. I also educate them about the side effect. Most of the side effect is dose dependent. The more the dose, the more the side effect. And of course is meals related. If it is fatty meals, of course, definitely will have more side effect than others. Most the drop rate happened more in higher dose of 15 milligram. You see more GI side effect like diarrhea or even constipations also can happen. So starting and quitting tirzepatide, just to remind you, I'm sure you will enjoy the rest of the lectures talking about the new indications of tirzepatide about sleep apnea and the HFpEF, which is really a very actually good news that we have a medication now that help our patients in that term. So happy to attend this launching in sleep apnea as well as also the heart failure. So we start with 2.5 milligram and then it go to 5 milligram after 1 week, after 1 month, and then you escalate it to 7.5, 10, 12.5, 15. And this, it depends on the individual. So you shouldn't just give a prescription escalation without guidance. You should actually monitor your patient and gradually till you achieve the target, A1C, target, weight, and of course to assess the side effect. All of these things play part of it. And always tell my patient, we are treating obesity is not a cosmetic problem. It's basically a medical problem that should be treated and disease. We are targeting a lot of things here. We have medication now can help our patient with the sleep apnea, fatty liver, heart failures, and a lot actually of things. So we are talking really a complex disease with a multiple systemic problem. So with that, I conclude, and thank you very much for nice listening.
Shukran, Dr. Walid, for your presentation. The discussion will be at the end. So we'll move to the international speaker, Dr. Qamar Eddin Mohammed. He's a consultant in diabetes endocrinology and general internal medicine at Whole Royal Infirmary Service as pediatric physician and associated clinical dean and curriculum advisor for diabetes and endocrinology, United Kingdom. Welcome, Dr. Qamar Eddin. So you will
Thank
talk
you very
to
much.
us about tirzepatide and obesity from evidence to practice.
Thank you very
Welcome.
much, Professor Abdul Rahman, for that generous introduction. I just want to say I'm extremely grateful to the organizers for inviting me to be part of today's program. It's an honor and privilege. I must also thank the organizing committee for the meticulous timing in the program, in the sense that you have not only allowed me to speak this evening, but also given me some time to watch the England versus Croatia match in the World Cup in a short while. So that was very thoughtful of you. And I now try to advance the slides. Let's see if I can do that. So first slide to you. Thank you very much. So obesity, the global epidemic. What are we talking about? So just bear with me. I go back to that slide. It's advancing a bit on its own. Bear with me. Yes, obesity, the global epidemic. Currently, there are 1 billion men living with overweight and obesity in the world. Currently, there are 1.1 billion women living with overweight and obesity in the world. So that's a current problem. But we also have a problem ahead of us, which many in the audience may not be aware of. The Lancet paper last year tells us a dismal story that by 2050, which is not very, very long, by 2050, 60% of children between the ages of 5 and 14 will be living with obesity, a truly dramatic problem. Positively, however, you can see here that many world organizations, and listed out here, WHO, etc., in their definition, they've used a really important word, a single word that has 7 letters, and you will see this word like a thread throughout the presentation. And the word I want to draw your attention to at the center of the slide is actually chronic. And that's really heartwarming to see organizations using the word chronic, because the word chronic has relevance to you tomorrow morning. Tomorrow morning, when you issue a prescription or issue counseling strategies or prescribing strategies. A chronic problem requires a chronic solution. So this, therefore, word, the simple word, underpins many of the questions that will arise. Why are we concerned about obesity? Because simply put, there are more than 237 complications of obesity. And a person with a BMI of 40 has a 50% chance of reaching the age of 70. And that's simply because of the complications. So obesity here, you can see chronic, which means I need to be doing something always. It's progressive, which means if I don't do something about the condition, it's going to get worse with time. It is relapsing. If I stop doing what I'm doing, the disease will recur. And there are multiple paths to the development causation of obesity. Essentially, obesity is a brain disease. Deep within the hypothalamus, it's a brain disease in causation. So above the neck is the cause of obesity. Below the neck are the complications of obesity. That's what we say in the obesity world, right? Now, crucially here, you can see that there are several factors which are amplified in the next slide, which I'm going to show you. So here you can see that we need to move from blame to biology because of the multifactorial causation. What do I mean by that? Yet still today, we have recommendations to patients to treat obesity. In my last patient this afternoon in clinic, being told by other colleagues, eat less, move more, and that will solve obesity. Whereas 40 to 70% of our body weight, we had no choice. It's genetically determined. And you can't really see this, but I want you to try to get the last reference in this slide. If you compare very closely, look at the last reference in the slide, what you're going to see is that 1990, we knew of the heritability of obesity, more than 30 years. Yet still today, we blame patients. We say obesity arises because of lack of willpower. It's a personal choice, and there's so much stigma with obesity. Moving on to the next slide, which is positive in nature, I want to say something here that this slide really forms the basis of goal setting, the basis, for example, of your clinical consultation. However, patients are focused on numbers on the scale, isn't it? You can see the benefits here of several parameters listed on the left, and increasing weight loss, you can see the benefits. And patients are focused on numbers on the scale. But we as healthcare professionals, we are looking at health gains, which are clearly described here. So I'm going to take two examples. If you look at the top, dyslipidemia, you can see triglycerides continue to decrease significantly with weight loss. Why is that? Triglycerides are a measure of ectopic fat. If we look at hyperglycemia, you can see that improves. Overnight, the liver releases 10 grams of glucose per hour to feed our brains. With insulin resistance in obesity and type 2 diabetes, that is increased by 45 to 50%, causing hyperglycemia. Treating that with the weight loss, we overcome insulin resistance with an improvement in glucose control. But the last point I want to make about this slide is this: there's something missing from this slide. There was a key thing which is missing from the slide, which we can't measure. We talked about all the parameters on the left, but can you imagine the reduction in anxiety, the improvement in self-image, in mobility that comes about because of weight loss? So we can't capture that very objectively, but that should be a cornerstone of what we do in clinical practice. Which leads us, therefore, to the obesity guidelines, moving past BMI. And we should move past BMI because BMI is a 19th century statistical tool invented by a mathematician, not a clinician. In 1972, Ansel Keys brought that BMI into our vocabulary. But you and I know in this audience the limitation of BMI. BMI tells us nothing about body composition. It tells us nothing where body fat is. It tells us nothing of how sick the fat is, how dysfunctional the fat is. So the EASO took a very mature approach to obesity. What did it say? Start with BMI, but then you should proceed in the clinic to assess on 3 domains: medically, look for which of the 237 complications do you have diabetes. Look at the functional status, that is activities of daily living, for example. Look at the mental health domain and classify is your anxiety, food insecurity, etc. And then we can proceed and initiate interventions and intensify therapy. Only then we can make plans. So we are clinicians and we like cases. This is what we do. This is what we're trained to do. So let's have a look at Mana, who is caught in a vicious cycle. She's living with obesity, doesn't have diabetes, and has had varying success, but also failures, so to speak, in terms of weight loss and maintaining weight. And she's worried. She's worried. There's anxiety on 2 fronts, if you look at it. The first is her current status of health, but she's also worried about the future. What is going to happen to me in terms of functional status, comorbidities, etc. She's currently battling the mechanical problems related to weight, but she also has a profound problem coping with the psychological dimensions of obesity. So what Mana does not know, And what many of our colleagues outside the obesity world does not know is what's on the next slide. And what's on the next slide? We don't understand the biology, the physiology of weight loss and weight maintenance. And this slide captures some of it. We're going to repeat this slide, but here it tells us that our energy balance is governed by two pathways, what we call the orexigenic signals, which drive hunger, and the anorexigenic pathway, which promotes satiety. So when any one of us will lose weight, then it triggers two responses. One, resting energy expenditure falls by 500 calories per day. And secondly, there was a fundamental increase in appetite, and this is driven by powerful endocrine forces acting upon the hypothalamus. That's the cornerstone of this slide. Manar thinks she's failing because she doesn't understand this physiology. So, again, there's a bit of delay. So what we are seeing here, we have just seen the two challenges. Weight reduction, therefore, tells our biology to pull us in two directions. When we lose weight, there's an intense desire, increasing desire for food at the level of the hypothalamus. But secondly, we are burning fewer calories, and that creates an energy gap, and the energy gap fuels the weight regain. This is the summary of the slide. So, if that's the case, we are faced with this challenge of weight loss and weight maintenance. We need powerful tools. We have just seen this is one of the biggest challenges that patients come and tell us every day in clinic. Doctor, how can I lose weight? How can I maintain weight? Because biology pushes back after weight loss. So patients have been asked to maintain weight loss, but the brain is telling us, eat more. Our resting energy expenditure falls. So there's a powerful physiological defense of our body weight. We therefore need a powerful, effective tool to cause weight loss and to maintain weight loss. So if we are saying that we have a powerful tool in the form of tirzepatide, we need to provide the evidence for that. And I'm going to show you in this particular slide, SURMOUNT 4. There's a SURMOUNT program, but we've chosen two trials for you briefly to show you, 2 slides each for each trial. So this slide has about more than 200 words in it. So just listen to 4 things I have to tell you, which is a summary of this. Forget 250 words there. Think of 780 patients, all receiving tirzepatide for 36 weeks, all of them, in order to induce weight loss. After 36 weeks, the patients are divided into 2 groups. Half continued tirzepatide, and the other half received placebo, and this continued for a total of 52 weeks. So 52 weeks after the separation. And then, over that period of time, we are tracking one index. Let's see what happens to body weight. So that's the summary of the SURMOUNT 4 trial. And what this trial told us is that from the start to the treatment arm, 88 weeks, patients lost 26% in their body weight. Whereas you can see here, in the placebo arm, they regained more than 50% of the weight they lost and ended up with only a decrement of about 9.5% from baseline. And this proves exactly what we know, that when we stop treatment, biology returns. This is not medication failure. This is not patient failure. Obesity is a chronic disease. It has not gone away. It is still there. Chronic disease requires chronic treatment. None of us will treat high blood pressure for 6 months and then be surprised when we stop treatment that the blood pressure comes back up again. None of us will treat dyslipidemia, for example, with statin therapy for 3 months, stop it, and then be surprised that the LDL doesn't remain suppressed indefinitely. It will rise. Chronic disease, chronic treatment. Okay, so I brought this slide back to show you again. This is a deliberate repeat to anchor this point that the weight regain is not lack of moral fortitude. It's not lack of willpower, but it is the re-emergence of powerful biological forces. So when the weight returns, biology returns. Okay, so you've seen this. I'll skip this one because it's a repeat. And I want to show you this. And you're probably thinking, why am I showing this particular slide? Why are we viewing this slide? This is SERMAT 1 and 4, cardiometabolic improvements. Well, we know for sure, everyone in the audience knows that tirzepatide will induce weight loss, isn't it? It will induce weight loss. Patients, of course, look at the numbers in the scale, but we as clinicians, we want health gains. And this shows you the several cardiometabolic parameters here. The real issue is what tirzepatide will do for health. And you can see the markers here with circumference, systolic blood pressure, lipids, and you can see here the improvements, the health gains. So these are more than numbers in the scale. This represents powerful cardiometabolic mitigation improvement. So adverse reactions, and again, these are common reactions which you will recognize, which our previous speaker, Professor Al-Bakr, has mentioned already. In this SERMAT 1 trial, for example, it mirrors what we see in clinical practice. There were mild to moderate gastrointestinal side effects, especially at the escalation times, and with appropriate advice of the relationship with food, we can mitigate those side effects. And reassuringly, discontinuation rates were low due to gastrointestinal side effects. So mild to moderate, and again, low discontinuation rates, which are reassuring for us as clinicians. If you'll permit me then, just briefly to show a couple of slides now on the SERMAT 5 trial. Why are we showing this? Well, SERMAT 4 showed why treatment should continue. You as a clinician are going to ask me then, well, if I'm going to treat obesity long-term, which is the most effective treatment to hand, the most effective tool we have to hand in order to treat the chronic disease of obesity continuously? And SERMAT 5 answers that question. I just want to point out that this was again published in the NEJM, widely considered to be the leading general medical journal in the world. There are more than 250 words on the slide. So just remember 4 lines that I'm going to tell you. 4 lines. First, this was a head-to-head trial with semaglutide, 1.7 to 2.4 milligrams, that's weekly, versus tirzepatide, maximum tolerated dose. 750 patients were living with overweight or obesity, no diabetes, randomized 1-to-1, 72-week duration. A single question we're asking is the primary endpoint: which agent produced greater weight loss? So this is SERMAT 5. And there's a little delay in this tracking. Yeah, it's there now. You can see here clearly, right? And these results matter for us as clinicians. You can see that both agents cause weight loss. But very early, on the left-hand side, you can see very early the curves start separating. And they continue to separate such that at 72 weeks, there was a clear 6% difference, greater weight loss with tirzepatide compared to semaglutide at the maximum tolerated dose. So this is not, it's more than a graphical number. This can alter the health trajectory of our patients. So this tells us there was clear superiority of tirzepatide over semaglutide in terms of weight loss. 6% clear difference. NEJM, public domain, you can have a look and verify if you so wished. Now, I'm going to show you another slide based upon this particular trial, right? When it loads, I've pressed, and it is loading a bit slowly. So maybe the team can help me. Okay, yeah, we got it there. So the previous slide told us the average weight loss difference. But this slide tells us what it means for the individual patient. What do I mean by this? At every clinical threshold, whether it's 10, 15%, 20%, 25%, it is clear that more patients reached their targets with tirzepatide compared with semaglutide. And astonishingly, 1 in every 3 patients, 1 in every 3 participants achieved 36%. You can see a 25% weight loss with semaglutide versus 36% with tirzepatide. Hugely important, relevant to clinical practice. So again, clear superiority of tirzepatide over semaglutide seen in this trial publicly available for you to have a look. There was one other index in this particular trial. I'm just looking at my time to make sure we have enough time. Yeah. And this tells us here waist circumference. Why am I talking about waist circumference here to you this evening? Well, it's a proxy marker for central adiposity, and it tells us, therefore, that here's tirzepatide leads to a 20 centimeter reduction in waist circumference compared to 14.7 with semaglutide. Superiority in central adiposity reduction. What does this mean? For the patient, it might mean shopping at a different high street, for example, in the UK. Functional status will be better, able to tie their shoelaces, perform personal hygiene. For the healthcare professional, however, in addition to these things, we know that this is a proxy marker for metabolic health because abdominal fat is linked with cardiovascular disease. Now, the question you're going to ask me here with this superior efficacy of tirzepatide, is it tolerable? Is there, for example, worsening side effects? And this, again, is quite reassuring. This slide gives us reassurance that although there is clear superiority and efficacy with tirzepatide over semaglutide, no new safety signal concerns were seen. It's all the predictable, familiar gastrointestinal side effects, mild to moderate, manageable with appropriate advice, with low discontinuation rates, so all reassuring. How do we summarize this then? What we summarize at this stage is that tirzepatide compared with semaglutide, weekly injection, maximum tolerated dose at a 1.7 to 2.4 with semaglutide, 10 to 15 with tirzepatide. Tirzepatide yielded superior, greater weight loss. Furthermore, it enabled a greater proportion of the participants to achieve meaningful weight loss targets. There was a larger reduction in waist circumference with tirzepatide, a marker of central adiposity and possible cardiometabolic health, and reassuringly, without any new safety signals being seen. So in the last 8 minutes, I think I'm a bit ahead of time, you might be pleased to know, let's do a case. If that's okay, we are clinicians. There are only about 4 slides left, and we'll go through this. So this meet our 32-year-old patient who I saw in clinic. She has class 3 obesity with a BMI of 41.2, and you can see here HbA1c in the non-diabetic range at 40 millimoles per mole. Her presenting problem was actually mechanical issues, ankle pain, some musculoskeletal issues, but also prominently profound psychological distress because of her weight, her previous attempts, and of course, her previous consultations with people, with colleagues who were not trained in obesity, told eat less, move more, etc. The relevant medical history, however, is that she has some metabolic issues that we needed to confront. So there's established recently diagnosed hypertension. She has mixed hyperlipidemia. She has polycystic ovarian syndrome, amenorrheic for 4 years, does not want to see the doctor because she saw the doctor before and told lose weight, periods will return. And you can see the dermatological complications. And for a young lady, what does that mean in terms of appearance, in terms of socialization? She's barely tolerating metformin. So addressing her, what we did is to share our treatment goals with her. It is much more than handing a pen with a powerful agent to her. What we need to do is establish global health on all fronts. We need to treat the biology, the food noise that she's experiencing. We need to curb that. We need to be able to use an intervention which will overcome insulin resistance and mitigate the cardiometabolic risk. Her functional status needed addressing, and powerfully, we needed to address her mental health, because mental health underpins 80% of obesity that I tend to see in clinic. So this is what we saw. This is the baseline data. When it loads, and you can see, you notice already, class 3 obesity. And she qualified for pharmacotherapy on the basis of repeated attempts with clear evidence of musculoskeletal, dermatological, and metabolic complications of obesity. Started on tirzepatide together with this, all the other interventions, including lifestyle intervention in terms of understanding relationship with food, resistance physical activity, and I think I'm approaching the end. If you give me 2 minutes, I'll finish here. And crucially, CBT. Why CBT? Because we wanted to challenge the shame-based thinking that she had, address the adverse body image that she was experiencing, change the script from I have failed into I'm learning how to care for myself. So we started at home, not at the gym, to preserve her dignity and to improve her mood quality. And this is what we saw. So Tirzepatide starting 2.5, we had a difficult transition to the 5 because eating habits, reduction in fatty food composition, reduction in meal size was not embedded. But after that, it was reasonably plain sailing with the nausea only at the times of escalation. And she was able to tolerate this together with the lifestyle intervention. We saw significant benefits. You can see the dimensions of input: psychological, dietary, physical activity. End result, what we saw? Significant weight reduction here, 22% weight loss. She's done class 1 obesity. We were able to discontinue Ramipril for blood pressure. Cycles returned. She started to think now about starting her own family. And HbA1c went even further down, although she didn't have diabetes. So the clinical impact here, you can see on the metabolic factors, the dermatological conditions improve, insulin resistance fell, and therefore her androgenic profile improved. And again, she began to be able to plan the pregnancy. So this here is the end. Thank you very much for this, and we're happy to take questions and during the question and answer session. Thank you. I hope I haven't overrun, and apologies if I have.
Thank you, Dr. Muhammad. No doubt about the benefit of Tirzepatide, but the problem with the continuation. And now we'll move to the other indication from Riyadh, the Dr. Manna Al-Shahrani. He's a consultant sleep medicine, King Fahd Medical Center, Saudi Arabia, National Lead of Sleep Medicine, Minister of Health, Executive Director of Saudi Sleep Medicine Society. He's going to talk to us about the other benefit rather than weight loss of the Tirzepatide, the redefining of outcome in obesity and obstructive sleep apnea. Welcome, Dr. Manna. الصوت.
Assalamu alaikum.
عليكم السلام.
Good evening, everybody. Thank you, Prof. Abdurrahman, for this introduction. Just to correct, my name is Mana وليس مناع.
مناع.
Also, thank you for بحالك الله يحفظك. Thank you
Welcome,
for
Dr. Manna.
Lily for this invitation, and it's my pleasure to be in the front of our colleague and some of my teacher in this event this night. Today I will talk about one of the new approved disease for Tirzepatide, which is obstructive sleep apnea, as one of the complication of obesity. First of all, this is my disclosure. I don't have any shareholder with Lilly, except I received my honorarium for the speaker and advisory events. So what is obstructive sleep apnea? Obstructive sleep apnea is one of the common sleep disorders that affect many people, result from many factors. One of the most factors is it's obesity. There is around 425 million worldwide living with the moderate to severe obstructive sleep apnea. If you talk about more simple cases, or we call mild obstructive sleep apnea, to reach up to 1 billion. So it is happening when there is upper airway collapsing during sleep, either complete, we call apnea, or partial, we call hypopnea. So it is characterized by complete of the upper airway, leading or continuous by intermittent desating, fragmentation of sleep, arousal to the brain activity, and increase in the heart rate, also increase in the inflammatory marker. So it is this event can be consequence with many complications happening behind this event, making our body in the flight mode. So what is the sign of the symptom of the obstructive sleep apnea? There is a many sign of the symptom, not necessary to each patient coming with the same sign and the same symptom. Many patients coming with the excessive daytime sleepiness, which is one of the serious complication or serious symptom that can be lead to the 20% of the road traffic accident globally. And here in Saudi Arabia, we have around 12% of the road traffic accident can be result from excessive daytime sleepiness. Other symptom is coming with the classical symptom like snoring, choking, witness apnea, morning headache, dry mouth, gastroesophageal reflex, fatigability, affect the concentration, maybe coming with the insomnia symptom, excessive dreams. So it is different from patient to another patient. So what is the connection between the obesity and obstructive sleep apnea? Actually, it is a bidirectional connection. As we know, obesity can lead to obstructive sleep apnea by two modality or two pathophysiology. The first one, which is accumulation of adipose or the fat around the airway, which lead to the narrowing of the airway and collapsibility of the airway during the sleep. Another mechanism which also impaired of relaxation or movement of the respiratory symptom happening as a restrictive pattern affecting the lung volume. That also can be worse of the obstructive sleep apnea symptom. What about obstructive sleep apnea symptoms? It can lead to obesity. Yes, as you mentioned, this event happen more than or recurrent intermittent event per time that lead to desaturation, increased inflammatory marker. The main issue here, or main important thing, which is dysregulation of the appetite hormonal control system. Leptin, which is one of the important hormone in our system, will be increased, and decrease, and the ghrelin will be increased. This is affect the appetite, leading to the patient with excessive eating of the carbohydrate or carbohydrate craving, especially at the night time. So it is bidirectional relationship. It can lead to the obesity, and obesity can cause obstructive sleep apnea. Is there any consequence or is there any complication of obstructive sleep apnea? Is it need to be treated? Yes. There is a many complication. Every system of the body can be affected or complicated by one of the disease. The first one, it is hypertension. Study shows around 42 of the patient living with obstructive sleep apnea have hypertension. Also, around 70% those with the resistant hypertension have sleep apnea. We talk about heart failure. Yes, study shows that increase of the recurrent admission, which is the cost or excessive cost of the healthcare system for those with the heart failure and obstructive sleep apnea. And also uncontrolled or untreated obstructive sleep apnea can lead to heart failure. Especially 2.56 times for those, comparing with those without non-obstructive sleep apnea symptom. What about coronary artery disease? A study shows that from 40 to 50% those patients can be high risk for development of acute coronary disease. What about stroke? Yes, it is one of the risk factor. Study shows that 2.5 increase in the fall to develop stroke for those patients with obstructive sleep apnea. Type 2 diabetes mellitus also can be one of the risk factor for those patients with obstructive sleep apnea. Is leading by starting by insulin resistance, then ending by develop the type 2 diabetes. What about depression? Yes, it's one of the complications of obstructive sleep apnea. Recent study shows that around 50 to 55% of those patients can complaining of either diagnosis of depression or symptom of the depression. So weight loss, it is the key factor for treatment those patients with obesity and obstructive sleep apnea. Study showed that any 10% increase in the weight gaining can be increased 32% increase in the AHI. Also, 6 times or 6-fold will be increased to develop obstructive sleep apnea. What is the AHI? It is apnea-hypopnea index, which is the diagnostic or metric tool can be result from polysomnography or sleep study to classify the severity, to diagnose and classify actually the obstructive sleep apnea. The normal population less than 5, from 5 to 15 will be mild obstructive sleep apnea. From 15 to 30, it is a moderate. Above 30, it is a severe obstructive sleep apnea. In the opposite side, any 10% reduction in the weight can be lead to 25 reduction in the AHI. So what is the recommendation for treatment of the obesity for those patients with the obstructive sleep apnea? It is the same recommendation for any patient with the obesity, with the chronic disease. More than 25, usually we start by physical exercise and reduced calorie intake with intensive lifestyle modification. For those with the BMI for 25, 27 and above, we can start by pharmacotherapy. For those with the above 35, we can add or refer for bariatric surgery. So we'll go to now to surmount OSA. It is one of the study design have been a study to assess the effective tirzepatide in obstructive sleep apnea for those patients with the obesity. Actually, it is a two study that has been phase 3 double-blinding randomized control study for 52 weeks. The first study was done in those patients with the obesity and obstructive sleep apnea, not using CPAP. Another study is done for the same population with the obstructive sleep apnea patient and those with the obesity BMI more than 30, but those using CPAP. Sample size was same in both two studies, around 235 and 234 in the first study and 235 and the second study. They start to escalating the dose of tirzepatide, starting from lower dose until maximum tolerated dose. So what is the primary endpoint for this study? It is change in the apnea-hypopnea index after 52 weeks from the baseline. Actually, if you look there for this graph, the baseline for apnea-hypopnea index for both two studies is around 50. And they drop the first study until 27 per hour, and to the second study with those on the ABAP or CPAP until to the 30 event per hour. So this is the main endpoint, which is change the number of AHI from the baseline. The second point or secondary endpoint, which is the percentage of a change in the AHI, as we show, there is a change around 55 in the study when those without only on tirzepatide without CPAP, and also around 62 for those patients with tirzepatide and CPAP. What about how much of the percent get effect more than 50% for achieving to loss with debate and improvement to the obstructive sleep apnea? For the study, when around 62% has been achieved reduction more than 50% in the AHI. Another study, they reach around 74 of the population in the study have been achieved to reduction in the AHI. What about normalizing of obstructive sleep apnea? We call normalizing if the AHI coming below than 5, or it's coming as a mild, as we mentioned, from 5 to 50. And the study when around 43 of the population that involved in the study has been either normalized or mild obstructive sleep apnea. In another study or study 2, those in the BAP therapy, around 51 of those population have been normalized from sleep apnea or be at least coming to the mild obstructive sleep apnea. Usually by guideline, mild obstructive sleep apnea not be treated until this patient have symptomatic or he has a chronic disease. We'll start him in treatment by approved to the most of the Society of Sleep Medicine. So what is the change? One of the secondary endpoints is change of the weight after the 52 weeks done. There is the study when there's around 80% reduction in the weight from the baseline. The baseline was around 170 kg, and by 18% reduction in the study 1, and also 20% reduction in the study 2 for those with using tirzepatide and BAP therapy. So what about the most reported adverse side effect? This is the same side effect has been discussed with our colleague in the previous study. Most of the side effect, it was GI upset, nausea, vomiting, constipation, and also has the same percentage of the other surmount trials. And actually no serious adverse side effect has been reported in this trial. So we'll end by this case from our clinic, which is a Mr. X. He is coming to our clinic complaining from obstructive sleep apnea symptom. Actually, he has snoring, choking, vivid dreams, and witness apnea and daytime fatigability. Actually, he was health worker, so he is suffering from excessive daytime sleepiness during his duty. Once his evaluation, he is a male, BMI was around 36, he's a class 2 obesity. Also, he has a stop bank around 5. Stop bank, it is a screening tool for obstructive sleep apnea. It is one of the famous with high sensitive tools can be used for screening of obstructive sleep apnea. Also, we talk about Epworth Sleepiness Scale, which is the questionnaire or screening tool for excessive daytime sleepiness. Above 10, that means abnormal. For our patient, it was 12. Actually, polysomnography was done. They found, in summary, apnea-hypopnea index was moderate. AHI was around 25, with the desating around around 85. So this is the baseline characteristic. BMI has obesity. BMI is 36. Actually, AHI has 25, which is a moderate obstructive sleep apnea. Also with the desating or intermittent desating reaching 85 during the sleep study. Also with the high risk score for stop bank. The agreement starting in his plan, we agree to start to chronic weight management. We agree to start Tirzepatide as a first choice medication. Also, we start him in the same time as automatic CPAP. It is still the first line of treatment for obstructive sleep apnea. Later on, after 3 months, actually we start 2.5, then escalating dose to 5 milligram. The third month, we reach around to 7.5 milligram. All dose until the third month can be maximally tolerated, no side effect. Actually, coming to reevaluation after the third month or the third dose, actually his symptom is improved, snoring is improved, daytime improved, no more daytime fatigability. Also, he lost his weight around 84. Now his weight is in around 84 kg. Around 16% of his weight has been lost. All symptom has been improved. We agree to continue until all symptom has been resolved again. Then we will recommend to complete escalating the dose until he reach the ideal body weight. After that, we will repeat for him for a sleep study. If he is normalized and AHI coming below than 5, we can stop CPAP at the time, and we can assess him again because if he doesn't maintain the ideal body weight, again, obstructive sleep apnea will develop again. This was the last slide, and thank you for attention.
Yes, he is going to talk to us. Tirzepatide in obesity, heart failure, preserved ejection factor. Welcome, Dr. Khalid.
I think no one heard you. Anyway, I'm Khalid Al-Habib, professor of cardiology. What? Pulmonary طبعا. وبيجايني. Geriatrics. Bariatric طبعا. So now after these great lectures, how many of you think that A, obesity is a disease? يعني مرض زي السكر زي الضغط زي الكوليسترول. B, it's a behavioral thing. مشكلة في السلوك حقك. If you behave better, you do not need treatment necessarily. So do you know that of any country that recognizes obesity as a disease كمرض في القانون حقها? So today, to my knowledge, new knowledge, that actually Italy is the only country in the world so far, maybe other countries joined, I don't know, but the first country that actually recognized obesity as a disease, which basically means that has major implications in terms of healthcare policies. And it is a law, يعني دخل في القانون الإيطالي. Today in an article in one of the European Heart Journal journals. So without further ado, so just thought to set up the stage for myself. So go next. So these are my, so this is me. I practice at Jamiat Malik Saud. I'm professor of cardiology, interventional cardiologist. So the talk is about tirzepatide in obesity and HFpEF, or heart failure with preserved ejection fraction, which is a very tough phenotype of patients to improve on. And as you know, the definitions of heart failure as a condition to develop heart fails to pump enough blood to meet the body needs, whether because of reduced ejection fraction, but believe it or not, you might get a normal systolic function, which people always focus on. But what I want you to, next time you look at an echo report, echocardiogram, to look at the diastolic function, قوة الارتخاء القلب. So many of these patients actually present in a way very similar to heart failure with reduced ejection fraction, or quote unquote systolic heart failure, and heart failure with preserved ejection fraction, what used to be called 30 years ago or so, or 20 years ago, diastolic dysfunction or diastolic heart failure. So these are the cutoffs: heart failure with reduced ejection fraction, the less than 40% ejection fraction, and more than 50% is the HFpEF, and those in the middle between 40 and 50, HFmrEF, heart failure with moderate range. So these are the people between the heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. And those with heart failure with HFrEF, weakened heart muscle, ejection fraction less than 40%. They might have eccentric LV remodeling, low LV mass, while those with HFpEF classically have stiffened heart muscle, so they have impaired relaxation of the heart, although they might have normal or even supernormal ejection fraction, and yet they might present in heart failure symptoms very similar to HFrEF. You might not actually distinguish it from HFrEF clinically. So having a normal ejection fraction on the echo, don't be deceived by it. The patient might still have heart failure despite quote unquote normal ejection fraction. Typically, these people are having concentric LVH and high LV mass to volume ratio. It's a common heart failure, as you know, is increasing in public health concern, millions of people. Approximately half of the heart failure patients have HFpEF, so almost 50%. Heart failure is the leading cause of hospitalization, number one cause of hospitalization in patients more than 65 years of age. Readmission rates after hospitalization for heart failure can be up to 30% within 60 to 90 days, a major impact on healthcare costs and healthcare system. And approximately 1/3 of patients die within 12 months, and mortality up to 50%, up to 70% in 5 years. So you have somebody with heart failure, their mortality is higher than many cancers, actually. This is the heart failure registry that I led more than 1.5 years ago, more than 1.5 decades ago, rather. It is the first multi-center, multinational, multi-center, rather, registry of heart failure disease in Saudi Arabia, and we enrolled more than 2,600 patients with acutely compensated heart failure from several hospitals around the country. These are the mean age and the different distribution. You can notice the high prevalence of hypertension, almost 71%. Half of them have coronary artery disease, and exacerbating factors including acute syndrome, infections, non-compliance with diet, non-compliance with heart failure medication. And here is the point that around 73% have HFrEF. So around 1/3, to flip it, have HFpEF. So around 1/3, you remember the number that I told you, around 50% of heart failure have HFpEF. In this registry, which was around 15 years ago or so, basically 1/3 only have HFpEF. This might be related to a younger age population, our population, to the Western countries. So classically, heart failure in Western countries, around the average age of presenting with heart failure in the high 60s to the 70s, and in even North Scandinavian countries, even in the 80s. While you can notice here the average age, median age is 61. So we're almost 10 to 15 years younger patient presenting with heart failure compared to the Western countries. We have shown this in other registries as well, like acute syndromes. So it might be related that we have lower age at presentation, so hence maybe lower prevalence of heart failure with preserved ejection fraction, since HFpEF classically presents in older patients, particularly those with hypertension. The other thing, it might be under-recognized. So these are, or under, basically, they're not being picked up promptly or accurately through the healthcare systems. I already alluded to the high morbidity and mortality, 5-year event rate, mortality almost as high as HFrEF. So they're not lower risk than heart failure with reduced ejection fraction. High rate of readmissions, cardiovascular readmissions, whether because readmission in general because of cardiovascular events or infections particularly. So they are liable for readmissions, not necessarily because of cardiovascular events only. They are liable for a lot of other events as well that make them decompensate. تنتكس حالتهم ويتنوموا بسبب pneumonia, COVID, whatever, what have you, and so on. And this is the heart failure causes, high symptom burden, and significantly reduces quality of life. So almost 60% have mobility problems, 18% struggle with self-care, 41% report difficulty in performing usual activities, 66% experience pain, discomfort, almost half experience anxiety and depression. So it affects only, not only mortality and morbidity and readmission, but affects the whole quality of life. It's important not only to live long, but live long with a healthy life as well. This is the Kansas questionnaire. So the KCCQ questionnaire, very important. You read it a lot in heart failure data and trials. So this is what it alludes to. It's a classic international standardized questionnaire. Did I touch something? Okay. So it's KCCQ is a Kansas questionnaire for heart failure, and it includes assessing symptoms, functional limitations, and quality of life, discrepancy between actual and desired health and functioning. And the higher the questionnaire, it's out of 100, the higher it is, the better. The lower it is, the worse. That means overall worse quality of life and more impairment and in functioning. And as you can see here, the low summary score of less than QCCQ score less than 25 correlates with 1 year hospitalization and more association with New York Heart Association classification, which is a classic classification for heart failure patients. So the less the score, the lower the score is, the more symptomatic the patient, and the more impaired they are, the more likely to be readmitted. This is important because when we're going to come to the trial, this is a major tool to be assessed that has been assessed in these trials. What is the main objectives for treatments with heart failure? Basically, obviously, reducing mortality, something that has been very difficult in heart failure with preserved ejection fraction. Heart failure with reduce ejection fraction, HFrEF, has been really a classic success story in cardiology, where we were able to reduce mortality and reduce readmission by ACE inhibitor, by beta blockers, mineralocorticoids, and what have you. HFpEF has been really extremely difficult. Just to put this in the context, السياق مهم جدا in terms of reducing, improving outcomes. So unlike HFrEF, HFpEF, heart failure with preserved ejection fraction, really has been difficult to improve outcomes. So to have any drug that improve outcome is a major really breakthrough. So would be great to have reduced mortality, but would be really, really important to improve their quality of life. Many of these people are classically elderly people, hypertensive, obesity, have lots of readmissions, hospitalization. What they care about really is not necessarily improving their lifespan. It's about actually living in dignity and less impairment in quality of life, and able to help themselves and perform their own daily activity. Go to the bathroom, wash by themselves, and so on. So improvement of recurrent hospitalization and quality of life is a major thing in their lives. How about risk factors and comorbidities associated with HFpEF? Obesity is the big thing, as you know, diabetes, and multiple comorbidities. We heard about sleep apnea, severe lung disease, inflammation, cardiomyopathies, coronary artery disease, cancers, and so on. So HFpEF comes with its own cocktail as well, not only with heart failure, but also with other things. So the interplay between this triad, which is obesity, type 2 diabetes, and HFpEF, basically up to 80% of HFpEF patients also have obesity or overweight. Obesity is the main driver of type 2 diabetes. About 90 to 95% of patients with type 2 diabetes have obesity. Approximately half of them, of patients with HFpEF, have diabetes. And around 20% of patients with HFpEF have also prediabetes. So there's a big, basically a Venn diagram where you have many of these patients have all these three together. Patients with HFpEF and diabetes, many of whom also have obesity, have worse prognosis. So those with HFpEF with diabetes are basically have a worse outcome, as you know, compared to HFpEF without diabetes, and risk of recurrent heart failure as well if you have both HFpEF and diabetes, or compared to HFpEF without diabetes. And the risk for developing HFpEF in people with obesity was mostly related to visceral fat, as you can see here, the bars on the basically right side of the line of unity, which is basically increased hazard ratio for visceral fat, BMI, waist circumference, possess the greatest risk for developing HFpEF. So it's not just, and mostly basically waist circumference and waist to height ratio, more than 0.5. BMI is a crude measurement of obesity, but if you really in your clinic measure more properly obesity, better measure waist circumference, and even better waist circumference to waist to height ratio. Weight reduction improves HFpEF, as we know, symptoms and quality of life. We know this from bariatric surgery. We know this from weight reduction in general. So this is the first part of the talk, which is HFpEF, its impact on life, the definition, interaction with heart failure, obesity, and what have you. The second part, which is Tirzepatide for heart failure with preserved ejection fraction, HFpEF, and obesity, and published by major authors from around the world in the SUMMIT trial, published in the New England Journal of Medicine a couple of years ago. And the SUMMIT trial design is a randomized, multi-center, international placebo-controlled, double-blind, parallel phase 3 study. The study was designed to evaluate the efficacy and safety of once-weekly Tirzepatide in patients with HFpEF and obesity. And you haven't really seen here diabetes, by the way. So these patients basically have just HFpEF and obesity, and not necessarily diabetes. And the enrolled patients, 731 patients from multiple countries, and you can see escalating doses of 364 patients versus 367, and basically highlighting the issues that how come a study of around only 700 patients got published in the New England Journal of Medicine. It didn't need thousands and thousands of patients to really reach the primary endpoint, which we're going to talk about. So this tells you this has been very impressive to just recruit, to randomize 700 patients and to get the positive results and get it published in the New England. I think this is impressive. And this is the key. Who did you study? So the key inclusion criteria: age more than 40, BMI more than 30 or more, and chronic heart failure, New York Heart Association class 2 to 4, so symptomatic heart failure patients, not just stable heart failure, so those with symptomatic heart failure, and LV ejection fraction more than 50%, on stable guideline-directed medical therapy, so already receiving the guidelines therapies, at least one of the following as documented evidence of heart failure, so structural heart disease, including left atrial enlargement, elevated NT-proBNP, which is a hormone released from the heart that basically tells you that the patient is overloaded. So more than 200 picogram, the usual normal number is 100, so they require even higher number, 200. And without atrial fibrillation or more than 600, basically for participants with atrial fibrillation, because AFib increases the BNP slightly, and elevated LV filling pressure. So that basically tells you these are just not stable asymptomatic heart failure patients. So these are symptomatic. These patients are suffering. They already have evidence of volume overload. And EGFR less than 70 mil per minute, and a screening or heart failure decompensation within 12 months of screening, and limited 6-minute walk test, more than 100 meters and less than 400, and a low cancer score. Remember the cancer score we talked about, less than 80. So these are symptomatic patients. These patients need help. So they excluded basically sick patients, acute decompensated heart failure within 4 weeks, a recent myocardial infarction or stroke, structural heart disease, which is congenital or genetic, like HOCM, hypertrophic cardiomyopathy, because these are different phenotypes. Atrial fibrillation, which is very fast, more than 110, evidence of reduced ejection fraction in the last 2 years, end-stage renal failure. So this study does not apply to end-stage renal disease or requiring dialysis, severe lung disease, or type 1 diabetes or uncontrolled type 2 diabetes, more than 9.5 hemoglobin A1c. The primary endpoint, extremely important. What did they actually aim for? To reduce this outcome. So time to the first occurrence of the composite endpoint of cardiovascular death, which is a very hard endpoint, or worsening heart failure events. And these are the heart failure events. So heart failure hospitalization, urgent heart failure visit requiring IV drugs, oral diuretic intensification for heart failure. So these are hard endpoints. These are not just improvement in symptoms. These are major improvements in outcomes. And key secondary endpoints included the other quality of life stuff. So the trial was powered for primary endpoint, but other important endpoints, which are secondary, important to look at as well, which are the quality of life in terms of changing the 6-minute walk test, which is an important standard that we use in cardiology, percent change from baseline to week 52 in body weight, change from baseline to week 52 in high sensitivity CRP, which is a marker of inflammation, and changing the Kansas City questionnaire from baseline to week 52. Here is the SUMMIT trial efficacy results. So you can see here the primary endpoint, time to first event for cardiovascular death or worsening heart failure events. You can see here reduction, hazard ratio 0.62, which is almost 40% relative risk reduction. So around relative risk reduction of 38%, which is very impressive. So 5.5 events per 100 patient years. You can see here overview of each individual endpoint. Obviously, you can see here that the numbers overall from the worsening heart failure, recurrent events requiring IV diuretics, and so on, they are all on the positive sides of reduction. All in all, although if you take every single individual endpoint, it is not significant, but if you got them together as a composite endpoint, basically the primary endpoint was positive, because basically it was driven mainly by the heart failure reduction and hospitalization. If you got all these endpoints together, you get a positive composite primary endpoint, which is a very common in cardiology nowadays, that you don't only focus on one single individual endpoint, you get a composite of 3 to 4 endpoints together. Worsening heart failure events requiring hospitalization, significant reduction. The co-primary endpoint, which is basically effect on the health status, that was a co-primary endpoint. So the primary endpoint was cardiovascular death or reduction in hospitalization. They have also co-primary endpoint, which is basically adding the questionnaire as well. So that shows you that there is reduction in there's improvement in the questionnaire, and treatment with tirzepatide significantly improve heart failure symptoms and physical limitations. So that tells you that patient had reduction in symptoms and improvement in functional status, and change from baseline to week 52 in high sensitivity CRP is positive, which tells you there is another effect as well, not only in weight. There might be also anti-inflammatory effect, which brings us here to the primary endpoint, basically separation of the curves, which has been really very impressive. People really looked at the separation of the curves. You didn't need a lot of time to have these curves separate. They separated within few weeks of starting the therapy, which makes you wonder, the weight reduction didn't happen that early. So is there something else magical in this drug? We have seen this in other drugs in medicine as well. For example, the SGLT2 inhibitors. So there might be an additional effect independent of the weight reduction, because you wouldn't explain it based only on weight, that the two curves separate very early. And might be because of that high sensitivity CRP. Maybe it has an effect on inflammation as well, which is, as you know, has an important role to play in cardiology in terms of affecting the endothelium, oxidation, and promoting atherosclerosis. Physiological and laboratory measures, you can see here the effect on NT-proBNP, the blood pressure, a slight drop. BNP didn't be affected much, but there's a slight drop in blood pressure, which is, as you have seen previous cases, some patients do not only improve their symptoms and their weight and their diabetes, but also I've seen it even clinically, their blood pressure start to go down and their cholesterol start to drop as well. Safety results, as you know, the main side effects are GI side effects, constipation, diarrhea, dyspepsia, vomiting. And if you can see, serious adverse events overall happened in 26 versus 25.6% patients with more than one event. Obviously, it's a small trial to really be powered to really look at all these stuff, but it's reassuring that nothing going in the wrong direction in terms of serious events. So the main side effects are actually GI in nature. The adverse events occurring in more than 5% of the patients, you can see here the diarrhea, the patients more than one event, the diarrhea, the nausea, and so on. You can see higher events rate with this agent compared to placebo. So with that, I will finish, and thank you very much for your kind attention. I would like to
Shukran, Prof. Khalid, for your nice presentation. Before the last speaker, just if there is any question for Prof. Khalid, because
I just have to apologize. I have to leave immediately for another.
If there is any question for.
So I hope it was very clear. That's why you don't have a question.
It is very clear, really. Even I was having a question about the effect of tirzepatide. Is it direct effect or because of weight loss?
Yeah, not sure what really even the author themselves didn't know how to explain it in the discussion in the summit trial. It could be weight, it could be anti-inflammatory, it could be both. Is it the effect on reducing the basically the symptoms through, as you have seen, slight reduction in blood pressure and other cardiometabolic? It's probably a multifactorial and a combination of all of the above.
I think it is related to the anti-inflammatory because we saw patients, even the autoimmune diseases improve with weight loss with the use of tirzepatide. We might see in the future.
Hopefully. شكرا يعطيكم العافية.
شكرا Dr. Prof. Khalid for your nice presentation. We'll move to last speaker. Is Dr. Naweed Zaman. He's Associated Professor of Internal Medicine and Endocrinology, Consultant of Endocrinology, Department of Internal Medicine, College of Medina, طيب Medina Medicine, طيب University, Medina Medical Center, and also he is working in Faqih Hospital in Medina. He's going to take us through the tirzepatide clinical cases. Welcome, Khalid.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Prophet Rahman, for the introduction. Thank you, Eli Lilly, for the invitation. And I'm going to go through some cases. I know it's the end of the meeting, but we'll try to refresh you up with some of the real case scenarios that are only few out of hundreds of cases that we are actually seeing on daily basis in patients with obesity. So these are my disclosures. So thinking about obesity treatment is really, we have to start thinking about beyond the weight loss. And we're going to see that at least in this patient I'm going to present to you. She's a 29 years old female. She's an operational manager, whatever it needs, that she needs to walk a lot in her job. And really, she came to my clinic seeking treatment for obesity. Hearing her stories, she's tried multiple attempts to lose weight, every single diet you can think of, combined with the exercise. What she is saying that usually she's able to lose the weight, but she's not able to maintain it every time it comes back. And more recently, she's been working as an operational manager, which basically requires her to stand throughout her day for at least 6 to 8 hours along with walking. And she has developed bilateral knee pain, which is actually affecting her quality of work and quality of life and occupational performance as well. So when you look at her baseline, basically she weighed around 93 kilograms. And remember, this is a 29-year-old female. Her weight is 93 kilograms. Her BMI was around 37.5. She's pre-diabetes at presentation. She did not know about this until we evaluated by doing the blood work. Her LDL is 155. Her triglycerides are elevated up to 200. And her ALT was slightly elevated. So we discussed with her that she really has this pre-diabetes. And this is the only thing we think of, or we started to think of when we used to treat obesity for the last 10 years. But if looking at the different complications this patient has, so she has pre-diabetes, she has dyslipidemia, she has suspected muscle, and she has functional impairment due to the knee pain, which is the most important thing for the patient, and reduce work productivity. So long discussion, we decided to start her on Tirzepatide 2.5 milligram and escalated the dose to 5 milligram in a month. And we continue to follow her at least from every 6 to 8 weeks. And this is the usual thing I do, is to give the patient or ask the patient to follow up in the clinic after they escalate the dose, not before the dose escalation, because that will help me to assess their response to the newer dose and to talk about any concerns with the newer dosage they have. Along with that, I never do the Tirzepatide or any other weight loss medication without the support of our colleagues from the nutritional department, who actually also are trained to give those patients some advices about the exercise training based on the measurements they do. So if we think about which is the primary disease requiring treatment in this patient, if that question was placed 10 years ago, you're going to say only pre-diabetes. But now it's going to be pre-diabetes, dyslipidemia, obesity itself, how she looks, as well as the knee pain. So the question is not really whether she qualifies for the obesity treatment or not. The question is whether the intervention should be actually done to help prevent the progression toward diabetes. So in the early follow-up, in the first 6 weeks, she lost weight around 8 kilograms from 93 to 85. She complained of mild nausea, which was slightly higher with the 5 milligram dose. We discussed with her how adherent she is with the exercise program. And I'm able to look at the nutrition notes in follow-up, so I'm able to see how those patients are following. I know it's something challenging because patients will complain that they already know about the diet plan, but I think they have to stick to at least every couple of months, if not every couple of weeks, to visit the dietitian. And the next question comes in that what should we do? Right now, she's 6 weeks on the treatment. She has lost 8 kilograms. She's really doing good in her exercise program. Should we just maintain the current dose? Should we stop the escalation, thinking about that she might get more GI upset? Should we continue the dose escalation as per tolerability, or should we only focus and we should stop here and say, just, just go and do the lifestyle? So we have to remember that the early weight loss is actually is a very strong predictor of the long-term success. So this is all usually I'd say in my clinic. The early weight loss she had, she's extremely successful. She's going to lose more in the near future. And the mild GI symptoms are expected and generally are manageable if we give them the dietary advices and they are following that. So what we did is to escalate the dose. We decided to escalate the dose to 7.5. We continued the 7.5, and after that we continued, we escalated it at 10 milligram, and then I stopped at 10 milligram weekly. Following up, around 10 months down the road, we have a patient who was 93 kilograms. Now she is 65. Her BMI changed from class 2 obesity to overweight. Her A1C is from 5.7 to 5. Her LDL from 155 to 95. And her triglyceride is from 200 to 120. So what we are seeing is a functional outcome also, apart from the metabolic outcome we just saw in this slide. We saw that a complete resolution of the bilateral knee pain, improve the mobility and exercise tolerance, improve confidence in her daily functioning, improve occupational performance, and subsequently, because she's working harder, she got promoted with her company. So looking at the final results, if we think about it, what would you consider the most important or meaningful treatment outcome? Yes, as an endocrinologist, we're going to think about the percentage of weight loss. For the cardiologist, they're going to think about the improvement in lipid profile. We, as an endocrinologist, diabetologist, also we're thinking about normalization of HbA1c. But really what the patient is going to care about is really the resolution of the knee pain she presented with and improve the work performance and getting promoted within 11 months because she's working better. So this is where actually obesity treatment is not only about the percentage of weight loss. The patient has meaningful improvements. She showed meaningful improvement in all major domains of obesity disease, not only metabolic health, but we are talking about metabolic health, cardiovascular risk factors, occupational or physical function, quality of life, as well as occupational productivity. So what were the learning points from Ms. R? The obesity should be recognized and should be treated as a chronic disease, not as a lifestyle failure. Pre-diabetes is always an intervention, is an opportunity for early intervention. We should also think about the functional impairment that can have with those patients. She's young. So functional impairment can be a stronger motivator than laboratory abnormalities. Evaluate the obesity treatment using patient-centered outcomes, and multidisciplinary care team is essential to achieve that outcome. So usually it's not only the endocrinologist's jobs, the endocrinologist, the psychologist, the nutrition, dietitian, the educator, and so on. So early intervention in obesity, of course, can prevent the progression to type 2 diabetes. Tirzepatide with lifestyle can approach the weight loss outcomes historically seen with only with metabolic surgery before. Treatment success should not be just only by how much kilograms they lost. Sometimes I ask my patient to remove the weighing machine because sometimes they get obsessed about how much they are losing on a weekly basis. And improvements in mobility, quality of life, work productivity, they are, in my opinion, are all clinically meaningful outcomes. So the goal is not weight reduction anymore. It's really restoring health, function, and life participation. I'll go with the second case. The second case is another patient, and I named it as when the greatest barrier is not obesity. So this is a 44-year-old man, and he's been, struggling with obesity, overcoming the stigma, has multiple DVTs, and has been misdiagnosed with misinformation about contraindication for obesity treatment. So this gentleman has presented seeking the help after years of unsuccessful weight loss attempts. He described trying multiple dietary strategies. I think he has named to me about 20 kind of diet plans that he has tried. The diet niqat, diet kimyai, diet ma, diet, every single diet you can think of, he has tried. And asking about him, what's really frustrating that all these diet plans has helped him to lose few kilograms, but he has regained them back. But that's not the problem. So if you look at his medical background, he weighs 122 kilograms, and he said he used to weigh 144 kilograms. So in 122 kilograms, he still has a BMI of class 3 of obesity. Recurrent DVTs, he has a benign thyroid nodule. His maximum weight was 142. The best he could achieve with the restricted diet plans he had is to achieve 122 kilograms. Now look at the right side of the screen, the psychological barriers. So he was repeatedly criticized by family and his colleagues that he's not trying better. He's not been able to, he's not really focusing on his lifestyle. Probably he's sneaking, he's eating unhealthy food. He was told that he's not trying hard enough. He lacked discipline. During the consultation in the first visit, he was able, and even trying to avoid the eye contact because of his obesity from the amount of the stigmatism he got throughout. Previously, unfortunately, he was denied the pharmacotherapy, even though the obesity medication has been in the market for a while, because he has a thyroid nodule. So he came to see if he is eligible for the treatment. So remember, his weight is 122 kilograms. So if we look about what is the most important obstacle to successful treatment in this patient, is it really the recurrent DVT? Is it the obesity and the recurrent DVT, obesity stigma? So obesity is the underlying disease, but stigma here, it's as a major barrier for treatment. So the patient get repeated messages that he's failing the treatment and delaying, he's not able to seek the correct care for the treatment of the obesity. Additional history, so basically he tried, actually, the patient himself tried to go to different doctors to seek medical advice regarding the pharmacotherapy. He was told he was not a candidate. So they أغلقوا الباب في وجهه. He was not a candidate because he has a simple thyroid nodule. So I looked at his ultrasound. He has a right-sided thyroid nodule, which is only around 9 millimeter. Literally, it was a thyroid 2. There was no single ultrasonographic suspicious features in this patient. This patient has been suffering for the last few years because he has met physicians who were telling him that, you cannot go for obesity treatment because you have a thyroid nodule, or sometimes we heard that also because if you have hypothyroidism. This is the most common misconception I've been hearing and have no idea where they are getting this from. So the question is really, does having a benign thyroid 2 thyroid nodule is a contraindication for tirzepatide? Of course not. This misconception is the most common misconception that we usually face in our clinical practice. The box warning for the GLP-1 agonist on and tirzepatide relates to specifically to medullary thyroid cancer and MEN2 syndromes based primarily on rodent data, حتى مش human data. So a benign thyroid 2 thyroid nodule is not a contraindication for our a treatment. So failure to distinguish this benign thyroid nodule from MEN2 or the medullary thyroid cancer is really the physician failure. So what we did, of course, we decided to start him like our previous patient. We decided to start him on tirzepatide, 2.5 milligram. He had a very excellent background with different dietary plans, but I still needed him to see someone, even at least, just to, so he doesn't go like low-calorie diet that is less than what he needs for his weight. Along with the structured lifestyle support, regular clinic visit every 6-8 weeks, gradual dose escalation. So very interestingly, on follow-up, and I'm just giving you the last follow-up I had with this patient was a couple of weeks ago, which was almost 7 to 8 months down the road. So we're talking about a patient who started with 142 kilograms, reached to 122 kilograms with extreme diet, and is not able to reach more. He's now 80 kilograms. He has lost about 34.4% of his weight. We're talking about BMI that was 42 reaching up to 27.5. Percentage of body fat, because following with InBody with the dietitian was extremely beautiful, where he lost from 46 to 27%, and he lost some skeletal muscle mass, but that is expected in the journey of weight loss. But look at the percentage of the body fat loss, it was much higher in this patient. So the best outcome that can reflect the successful obesity treatment in this patient, is it only reduction in BMI, is it only reduction on fat percentage, is it preservation of the skeletal? So the treatment requires attention to body composition also, not only on the amount of the weight loss, because the goal is to maximize the fat loss. And I'm talking about patients who are not only using the tirzepatide as a source of treatment, but they're using tirzepatide along with the diet and exercise, along with the exercise in this group. So at his most recent visit, the physical transformation was completely obvious. I was not able to recognize him, honestly. However, what was more striking to me, that he was really the emotional transformation he had. He really was smiling. He engaged comfortably. He was making eye contact. He was literally smiling throughout those 20 minutes. For the first time, he expressed confidence in his ability to maintain his progress. So what was the most important outcome in this case? Is it really the weight loss? So that we think about weight loss, we think about the body fat percentage, but for the patient, there are some meaningful transformation that's happening in him. Now, one thing he told me, when I go to buy shirts or pants, I'm no longer looking for this XXXX large. I'm going to the normal size people. This is, for me, is giving a confidence, and I'm able to buy the shirts and pants like any other people. So we have to think about, like Mr. A, when patients come to us seeking help for obesity, we have to think about that obesity stigma is a major barrier. Sometimes patients are afraid to seek help to treat for obesity treatment because of the stigma. So the weight regain after diet is something normal. So I always say to them, my patient, usually majority of patients, when they are doing diets, they are losing, but they are not able to maintain it. This is not a personal failure. This is a metabolic adaptation. This is how our physiology body responds. A benign thyroid 2 nodule, again, is not a contraindication, please, for starting a GLP-1. Please remember that. Successful obesity treatment is not only an endocrinologist, a good cardiologist. It's a multidisciplinary team. I feel great when patients are being referred to our clinic from cardiologists, from gynecologists, from rheumatologists, from GI, just because they are noticing how improvement their patients are getting just because they're losing weight. And always, if possible, body composition can provide some more meaningful information that will make the patient continue this journey. So patients with obesity frequently face stigma from families, society, and healthcare professionals. Weight regain after dieting is a biological response. The misinterpretation of thyroid-related warnings, which is the most common thing it's happening, especially in our country, may unnecessarily deny the access for effective treatments. Tirzepatide plus multidisciplinary care can produce substantial improvement in weight and body composition. I'd like to finish here. Thank you very much.
شكرا Dr. Naweed for your nice presentation cases. So we'll start first. Well, I will ask the speaker to be to the stage. And, Dr. Walid. Yeah. So we'll start the question from Jeddah first, if there is any question.
Thank you, doctors, for nice presentation. The problem now I'm facing in my clinic with the Monjaro, all my patients told me when you stop the medication, we gain weight quickly. So please help us to give a regimen to keep what's going on, a nice achievement with weighting loss, everything. So I told them I have to decrease gradually, but after that, they gain weight and appetite again and again. So please help us for this problem. Yani we're facing a lot in my clinic now.
Okay, so your question is about the patients are losing weight, but after they lost the weight, they are eager to stop the medication and they are afraid to regain the weight. And I think we have answer for that. No, we have trials that has shown that stopping the medication very clearly is going to let those patients to regain their weight back. So it's a chronic disease that requires a long-term treatment. And I agree, it's a very challenging situation in the clinic that sometimes previously we were not used to face that, but we are getting more and more concerns regarding this, especially before they start the treatment, because now they are seeing that those patients who actually took the medication for a couple of months or 6 months or 1 year and they stopped it and they regain the weight back. So this is the chance for describing, the first thing I ask them, do they consider obesity as a disease? Do they consider it as a chronic disease? What kind of improvement they're going to get with medication? And then I'll keep them. Usually there is no clear answer for that, but it really depends on your patient, depends on how active your patient is involved in lifestyle, in gym, in exercise, personal trainer, all those things. So sometimes you can always try to see if you want to escalate the dose down a little bit and keep them, maintain them on something that is beneficial with the least possible dose for those patients, or just keep them on the same dose. In my humble opinion or experience, usually most of the patients are happy with their current dose, and they're only coming to you because they're doing the labs and they're just making sure that nothing bad is going to happen. Nothing bad is going to happen because everything that was going to happen with obesity is gone now. As long as they're tolerating the dose they have, then you should continue.
They should continue if they have the appetite again. If they if they're not able to continue the diet, they have to go back. I have a patient, 17 years, using the GLP since 2008 with the liraglutide, and now they are using the tirzepatide or semaglutide. There is no duration. You cannot say that only 3 years or 5 years. There is no agreed for how long you can use it, but as patient cannot control himself by diet, he should continue on it. There is no harm. There is other way I use sometimes, other treatment. If the patient reach to the ideal weight and he cannot take the GLP or because of the expense, we go for the like Contrave. I used it on those patients and we maintain their weight, but they have to do more effort. The patient need effort. He should know that the weight might come again if he not continue on diet. Some of them, they do that and they continue keeping their weight, but if there is problems in the diet, they cannot continue the diet. They have to go back to the GLB, and there is no harm from it, even if you continue for years. If there's any question.
Dr. Abdurrahman, if you allow me here, this is Mustafa Al-Azazi, the medical director here in Riyadh meeting room. Thank you so much for highlighting the answer regarding discontinuation or de-escalation, but just want to highlight that according to Mounjaro label, there is no guidance on de-escalation of the dose, and there is no specific guidance for discontinuation. It is based on clinical judgment. As long as the patient is tolerating the dose, he can continue on the medication as long as he is gaining benefit and tolerating the medication. And discontinuation or de-escalation of the dose is based on clinical judgment and patient response to the medication.
Clear.
Thank you.
Yes.
Is steroids 3 or 4 contraindication for the use of GLP-1?
What's the contraindication to use the GLP?
Thyroid nodule, steroids 4 or 3?
Yeah, the thyroid,
Is
as
it-
mentioned by there is no contraindication for the use of GLP, only if the patient had pancreatitis without known cause, and if the patient has medullary carcinoma, as this is only on the animal, even not approved, not seen in the human, but in animal, and there was some increase in the male rat of the medullary carcinoma. So, and it's very rare actually. Medullary carcinoma in our country is very rare. So if the patient, how you know it? By the, if the patient has family father, 50% of that, there is a lot of clinical things. What about thyroid nodule? It's usually the same as the other, if they come for diabetes. You examine him, you found thyroid, you have to go through it. If the patient found by ultrasound there is nodule, you have to go for need FNA or doesn't need FNA, depend on the how trade 4 or 5. Usually we go for FNA. If approved, there is nothing normal, benign, you can't give it. No contraindication. Even if there is papillary carcinoma, it's not contraindicated to use it. You treat the thyroid cancer, and if the patient has obesity, you can give the GLB receptor agonist, even if the patient has a papillary carcinoma. Today I saw one patient, one not given, because one of her relative had pancreatic cancer, which is not and not given as your patient the GLB because of that. This is not true. Any other question? Because we want to move to the agenda.
عفوا دكتور، بس هنا دكتورة فاطمة الكواي medical director Eli Lilly. Thank you doctor for your response. I'm here giving some feedback about our label. So in our label, Tirzepatide is not, we shouldn't use Tirzepatide if there is medullary thyroid carcinoma, and even if there is a hypersensitivity to Tirzepatide, or if there is pancreatitis as well. So regardless, yes doctor?
We answer it already. You don't need to clear it. It's very clear. So we want, because of the times, we want a question.
My question for Dr. Manna regarding obstructive sleep apnea. When should repeat sleep study for those patients after initiation of Tirzepatide? And did you think there is another mechanism beyond weight reduction for this patient regarding muscle function of airway?
Yeah, Dr. Manna.
Thank you for this question. Regarding the repeating of polysomnography after body or lose your weight, there is no consensus in any guideline. American Academy of Sleep Medicine, European Sleep Medicine Society, but the practical point, we do it especially in our patient, those with the bariatric, once they reach the ideal body weight, this is the time to repeat sleep study to confirm is the result of sleep apnea or there is still a remnant of sleep apnea, because as we know, obstructive sleep apnea is a multifactorial. So the practical point, once you reach the ideal body weight, just repeat polysomnography. Regarding the pathophysiology behind, is it related to the body weight loss itself or other pathophysiology? There is nothing has been commented from the author of the trials. Yes, we know there is a leptin resistance in some pathophysiology behind the obstructive sleep apnea itself, and obesity hypoventilation syndrome, which is a different disease more serious than the obstructive sleep apnea, but that has been discussed in the trial and the research. It is just mainly related to the result of the obesity and its effect in the respiratory muscle.
So the improvement in sleep apnea is seen also with the bariatric surgery, not only
Yes.
even with bariatric surgery.
Yes, also.
So I think we move to our colleague in Riyadh, if there is any question. Riyadh?
My question regarding the primary or secondary failure. We know this is a very effective medicine, but some people, they reach the maximum or the target dose of Manjaro or Tirzepatide. However, when we should consider that he has a primary or secondary failure after treatment, after continuing for 1 year, 3 months.
Dose of Tirzepatide, no loss of weight more than 5%. So if there is less than 5% loss after 3 months, and usually the failure from the GLP in general, it is due to not following the diet. Yeah, most of the patients, they take the GLP receptor agonist, either semaglutide or tirzepatide, and they eat chocolate in the night. So it is diet mainly. Where is it? So the indication for use of the tirzepatide, it's now for the obesity, diabetes, and also for the heart failure with preserved ejection fraction, and also in sleep apnea. This is a very clear indication and approved indication of tirzepatide. And we hope in the future there will be more indications, especially with the weight loss. And Dammam, there is any question? Dammam? I think we close because we are late. So thank you for all of you. Thank you for Lily. Thanks for the help you are giving us because of the weight treatment. Thank for everyone. Thank for all the speaker. يعطيكم العافية. ليلة سعيدة.
شكرا جزيلا. السلام عليكم.